So we've talked a lot about conditions with too few blood cells. You know, all those anemias. But what about too many blood cells? That's polycythemia, mes amis. In this sketch, we'll go over what happens when your circulation is crammed with more blood cells than it can handle. Polycythemia is defined as an increase in hemoglobin, hematocrit, and red blood cell count. These all go pretty much hand in hand. And in this scene, these lab values will be represented with a flower cart. See those hemoglobin-esque wheels? We've emphasized hemoglobin specifically since it's usually the first lab you look at. It's that first H in the H&H, part of every complete blood count. Now, the hemoglobin content of blood is measured as a concentration. That's grams per deciliter, about 14 to 17 for men, 12 to 15 for women. So let that DL on the cart remind you of volume in the denominator, grams hemoglobin per deciliter, or in this case, roses per cart. It's similar to hematocrit, which represents the volume of red blood cells over the total volume, and RBC count, which is the number of cells per microliter of blood. Because these are all concentrations, they can be affected by changes in plasma volume. Think of it this way. See that boat getting dragged out of the pond? As it loses water, the red lily pads get concentrated. Kinda like when your patient is super dehydrated from vomiting or diarrhea or excessive diuretic use. In all these scenarios, the plasma volume shrinks. This leads to relative polycythemia because you have an increase in red blood cells relative to how much plasma volume you have left, resulting in increased hemoglobin and hematocrit. This is actually the most common type of polycythemia. You don't have more cells, they're just more concentrated. Furthermore, because there's no physiologic need for more red blood cells and O2 levels are normal, erythropoietin levels are also normal. We'll get into erythropoietin more in just a moment, but for now, just imagine that these red tubes of paint are going to be used to produce red RBC water lilies throughout this impressionistic sketch. When the cap is off and red paint is getting everywhere, you'll know that erythropoietin is high. In the setting of relative polycythemia, however, the cap is on and erythropoietin is normal. As you might expect, the only thing you have to do to treat relative polycythemia is rehydration. Get plasma volume back up to normal, and everything else should normalize along with it. That was relative polycythemia. How about absolute polycythemia, which refers to an actual increase in RBC mass? Yeah, mass is different than RBC count. RBC mass is the total number of RBCs in the body, which is why this woman who's calculating the total mass of her purchase is covered with a rose pattern from head to toe. Again, this is the total mass of RBCs in the body, so it won't be affected by changes in plasma volume. Absolute polycythemia involves an increased production of red blood cells, which can occur for a number of different reasons. To make it easy, we'll separate the etiologies into two general categories: primary and secondary polycythemia. Let's start with primary, focusing on one of the primary founders of French Impressionism, Monet himself. In 1912, at the age of 72, Monet was diagnosed with cataracts, though his vision had been deteriorating for quite some time. I mean, just look for yourself. Over the years, his style took a turn for the, let's just say, more abstract. It got kinda muddy in quality, with a pronounced color shift from bluish greens to reddish yellows. Ed, what did I say about overdoing it with the red, huh? And water lilies? Seriously? Like the other 200 you did? Don't get me wrong. They're cool and all. It's just that Pablo's playing hide the salami with like 5 mistresses at a time, all while inventing another version of that cubism thing. Duchamp wrote his name on a snow shovel the other day, which was frickin' badass. I think it's time to branch out, don't you? You see that bone-shaped easel? This is primary polycythemia, so we're going straight to the source. The marrow. Primary polycythemia is a result of the bone marrow producing an inappropriately excessive number of red blood cells, hence the excessive amount of red water lilies on the canvas. It's most commonly caused by what's called polycythemia vera. And there she is, Vera. Well, it's actually his second wife's daughter, Suzanne. but let's just call her Vera. Polycythemia vera is a myeloproliferative disorder characterized by uncontrolled proliferation of red blood cells in the marrow, which increases RBC mass along with the RBC count. Hemoglobin and hematocrit increase too, all of it. And you see how that kidney-shaped palette is nice and pink and oxygenated? With all those extra RBCs carrying oxygen around, the kidney down-regulates erythropoietin production, as depicted by that erythropoietin paint tube, discarded on the ground. Decreased erythropoietin helps us differentiate primary, or bone marrow-derived, polycythemia from secondary polycythemia, which we'll see in a second. Back to Vera. Polycythemia vera is caused by a mutation in the JAK2 gene, symbolized by the CAR-JAK on the left. And since JAK2 is a cytoplasmic tyrosine kinase, think of it as a tired JAK. The most common mutation, V617F, replaces a valine with a phenylalanine at the 617 position, which results in constitutive activation of JAK2. Just madly jacking that tire off. The poorly chosen prepositions aside, this constitutively active JAK2 causes constant activation of the STAT pathway. Activated STAT proteins travel to the nucleus, where they activate genes important for proliferation and survival. The end result? Hematopoietic cells that are more sensitive to growth factors such as erythropoietin, proliferating with little or even no stimulation. You may have noticed that we mentioned hematopoietic cells, as in plural. Polycythemia vera also results in proliferation of other cells in the myeloid lineage, including platelets and granulocytes, such as neutrophils, basophils, and eosinophils. So remember that we're looking at a broader spectrum here. Everything but the lymphoid cells, which are B and T cells. A small aside about increased platelet production. Just like we illustrated at the Myeloproliferative Museum sketch, this doesn't necessarily mean increased thrombosis, though that's certainly a risk. It turns out when there's an overload of platelets in circulation, you use up all of your von Willebrand factor, which can increase the risk of hemorrhage. So remember, myeloproliferative disorders, including polycythemia vera, can cause both thrombosis and bleeding. But besides symptoms caused by either hemorrhage or ischemia, remember that, most of the time, symptoms are going to arise from increased cell mass alone. Just think of it as a blood-based fluid overload. Sort of like an erythropoietin overdose. Looking at you, Lance. Because of the massively elevated RBC count, tissues can get congested. You might even see some facial plethora, depicted here by this art student's ruddy complexion. Ruddy in embarrassment, that is. Then again, it's not that bad. It's, oh, I see it. It's a still life. Ice cream sandwich on a bed of lettuce, right? Nice. Congestion in the spleen and liver can cause these organs to become enlarged. Hence the hepatosplenomegaly paint splotches on the back of his smock. Blood viscosity can increase as well, which increases the risk of arterial and venous thrombosis, as symbolized by those thrombotic sticks clogging up the flow. On the arterial side, this means strokes and MIs, while on the venous side, there's an increased risk of superficial thrombophlebitis, DVT, PE, and all kinds of vein thromboses, including hepatic, mesenteric, splenic, and retinal. Small foci of thrombosis and hemorrhage in the CNS can cause headache, dizziness, and vision changes. Whoa, that guy does not look good. I don't know whether he's sick to his stomach after finally resigning to the fact that he'll never be as good as the French master of Impressionism, or if he just forgot that it's 1912, and we're in the middle of the 6th cholera pandemic spreading towards Europe. Either way, abnormal mucosal blood flow can lead to gastrointestinal pain. One of the most interesting symptoms of polycythemia vera is pruritus following a warm bath or shower. Or, in this case, warm, stagnant pond water rife with mosquitoes. This so-called aquagenic pruritus most likely occurs as a result of histamine released from mast cells. Remember, most myeloid lines end up being revved up in polycythemia vera, mast cells included. Here's another interesting one. Hyperuricemia and gout. Notice that we've brought back our recurring uric acid needles, along with that ball of yarn representing a gouty tophus. The breakdown of RBC DNA requires purine metabolism, remember, of which uric acid is a byproduct. When there's a ton of RBCs around, this happens way more frequently, resulting in elevated levels of uric acid and, consequently, gout. Over time, the bone marrow may even burn out, leading to a state called myelofibrosis. depicted here by this leafy and fibrotic bone marrow topiary. On histology, the functional fatty bone marrow is replaced by non-functional fibroblasts and collagen. Myelofibrosis is a late complication of polycythemia vera. With reduced blood cell production in the bone marrow, hematopoiesis shifts to the spleen and liver, a process called extramedullary hematopoiesis. In other words, you have yet another reason for the spleen and liver to become enlarged. Transformation to acute myelogenous leukemia, or AML, can also occur, manifesting as an abrupt proliferation of myeloblasts instead of mature cells. We represent AML with abstract art comprised of a bunch of malformed, immature splotches of color. Kinda like all those immature myeloid precursors just spilling out into the circulation. As you might imagine, when this occurs, prognosis is poor. Treatment is primarily serial phlebotomy, which, oddly enough, is probably what the treatment was back in Monet's day. Without treatment, patients quickly die from vascular complications. All right, now that we've covered primary polycythemia, what about secondary? Well, unlike primary polycythemia, in which erythropoietin levels are decreased as a result of negative feedback inhibition, secondary polycythemia involves increased levels of erythropoietin. In fact, it's because of the increased erythropoietin. So we've drawn in Monet's understudy here, bringing over 2 brand new erythropoietin tubes. That's 2 tubes for secondary polycythemia. Let's take a look at a few reasons why erythropoietin gets upregulated. Starting with the physiologic causes, and then going into the not-so-physiologic causes. See that blue face? The physiologic causes of secondary polycythemia are all driven by hypoxia. Reduced oxygen delivery to the kidney is symbolized by that blue, hypoxic-looking kidney palette. This stimulates the kidney to produce more erythropoietin, which then stimulates those red blood cell precursors in the bone marrow. You get the idea. Physiology doing what it's supposed to do. Conditions that induce chronic hypoxemia are the culprit here. Specifically, we're talking about lung diseases such as COPD, obstructive sleep apnea, cyanotic congenital heart disease, and living at high altitude, where there's low atmospheric O2. You know how marathon runners train at high altitude? Well, it's to boost those erythropoietin levels. Cheaters? Nah, just kidding, it's allowed. Nature's blood doping. For more info on these particular conditions, check out their corresponding sketches in the cardiology and pulmonary chapters. Bottom line, the term physiologic secondary polycythemia refers to the body's normal mechanism to adapt appropriately to a low oxygen condition. Sometimes, however, erythropoietin is inappropriately elevated. We call this inappropriate secondary polycythemia because it's just rude, really. Inappropriate secondary polycythemia is the result of an erythropoietin factory outside of the kidney. This generally happens with tumors that also happen to produce erythropoietin. The most common culprit is renal cell carcinoma, although other cancers have been implicated as well. This makes sense since erythropoietin is produced by the kidney. Just take a look. This fellow went into the pond to retrieve a few erythropoietin paint tubes, and he came out with a kidney-shaped net full of cancer crabs. Since erythropoietin is being produced independent of hypoxia, look for a normal O2 sat, which is why his face is happy and pudgy and pink with oxygen. O2 levels are just fine. And that's it for polycythemia. An important thing to remember about polycythemia vera specifically is that it's not just about abnormally high erythropoietin and red blood cells. Polycythemia vera is a myeloproliferative disorder. That's myelo as in red blood cells, granulocytes, monocytes, and megakaryocytes. It can even turn into AML, just like the other myeloproliferative disorders. In the course of the disease, however, many of the important clinical manifestations arise because of that increased RBC count. Facial plethora, hepatosplenomegaly, hyperviscosity, thrombosis, and neurologic stuff. All right, the 1910s were fun and all, but it's time to flash forward to the modern 1960s, when Roy Lichtenstein rises to prominence in the new pop art scene. The color palette is still very myeloid, though. Look out for his masterfully placed pink, blue, and white granules on the canvas as we dive into the myeloid neoplasms, AML and CML.